and welcome to yet another masterclass by none other than Dr. Abha Majumdar. And today's topic is going to be very, very interesting. It is a pleasure to listen directly from Dr. Abha about her favorite topic, which is stimulating the ovaries in PCOS. And we are going to know how to take a stepwise approach in an ovulatory PCOS. Ma'am, over to you. And
You,
let's start.
Tejasvi. And truly, it is my favorite topic. And in fact, I loved this topic when it was given to me in the AOGD workshop, that this was a question in the question paper which I set for FNB students. So we all understand that ovulation disorder happens in PCOS, which means infrequent ovulation, oligoovulation, or there could be complete absence of ovulation or anovulation. So these are two terms which are used, oligo and anovulation. Most of these women are not absolutely infertile, but subfertile. We encounter a complete spectrum of ovulatory dysfunction in PCOS, which at the smallest point is there is sporadic ovulation or even very regular ovulation in a lot of PCOS, and these girls may conceive naturally without even knowing that they have underlying PCOS. And on the other hand, it is often challenging to treat these women successfully and safely with various ovulation-inducing agents. So let us look at evidence. The International Evidence-Based Guideline for the Assessment and Management of PCOS 2023, the summary which was given forward by 7 big bodies of the world, which is Monash, ASRM, Endocrine Society, CRE-Will International Society, ESHRI, CRE-PCOS, and Endogenous Society for Endocrinology. They said letrozole is the first line drug for anovulatory infertility. And why did it become the first line? How did it supersede clomiphene citrate? It is because it led to a monofollicular development in 90% of cases. And hence the risk of OHSS could be minimized by this drug. The second line treatment consists of clomiphene citrate alone or in combination with metformin. Or the second line also has gonadotropins or ovarian surgery included in it. So please remember letrozole first line. Second line is CCA alone or in combination with metformin, gonadotropin, or ovarian surgery. What is the last line of treatment? In an absence of an absolute indication for IVF, women with PCOS and anovulatory infertility. Now, you understand that you're not being able to make them ovulate or they hyperovulate. For them, IVF potentially is the best choice. But then if you have not been able to make them ovulate, even with the highest dose of gonadotropins, then IVM is the third line therapy where other ovulation induction therapies have failed. So IVM is for women of PCOS where you've not been able to induce ovulation at all. Then you may undertake IVM or you may take IVF only when other forms of ovulation induction have not led to a pregnancy, or you have always been you sort of land up with a hyperstimulated ovary and you have to cancel the cycles. Having said that, we're going into the 2023 recommendation of the PCOS multiple societies, out of which the most important is that clomiphene citrate should be used. Don't use just metformin. In women with PCOS, use clomiphene citrate with or without metformin. And if there are no other infertility factors, to improve ovulation, pregnancy, and live birth rates. And another thing is clomiphene citrate alone, or if it is combined with metformin in women who show a little bit inclination towards metabolic syndrome, it is a good choice. Don't use metformin alone again. So monitoring of combined cycles will need to be equivalent to clomiphene citrate alone. So in clomiphene citrate, what do? We just monitor the first cycle at the lowest dose, which is 50 milligrams. And if she ovulates at this, you will continue 50 milligram. If she does not ovulate with 100 milligram, you can combine metformin. And if she ovulates, you find out the fertile period of hers, which are the days when she's likely to ovulate, one cycle needs to be monitored. And then you can leave her on this drug for the next 3-4 cycles without any monitoring. So whether you use metformin with clomiphene or clomiphene alone, the same dose leads to the same time frame of ovulation and hence need not be monitored. When can one start ovulation induction in an ovulatory PCOS? A woman comes to you that, I want to get pregnant, and maybe it is 2 months past when she had her periods. What are your answers? One is that either you give her withdrawal bleeding and then start on day 2 or 3, or maybe day 5 and 6, or any day after withdrawal bleeding in the follicular phase. You have to make sure that in this 2 months, she's never ovulated. What I do is look at the cervical mucus, and you can even do serum progesterone. And if it is less than 1, she's not ovulated. So in such cases, if the endometrium has not grown and all the hormones are baseline, which means FSH and E2, we can start ovulation induction at that point of time. But if the endometrium has grown to over 5 millimeter, it is better to give a withdrawal bleeding and then start her ovulation induction. Whenever ovulation is started on day 2 versus day 5 or later, the day 2 is always accompanied with more rapid follicular growth and multiple dominant follicles. So, as I told you, ovulation induction can be started any day post-menses with variable results in anovulatory PCOS. It would be equivalent to what you start on day 2, 3, 4, or 5. If you start on a later date, but you've made sure that she's in the follicular phase, there has been no ovulation, and the endometrium has not grown to over 5 millimeter. Anything you look for before starting ovulation induction in these women? First thing is, you've given her a withdrawal and she's not bled. You would rule out a pregnancy and ensure endometrial thickness is baseline. And this is what I'm going on telling you, that in absence of withdrawal bleed or otherwise, if you want to start ovulation induction in an ovulatory patient, you have to ensure endometrial thickness is baseline, and so is her E2 levels. If the E2 levels are less than 80, FSH levels wherever they are, 4, 5, 6, 7, doesn't matter, we can start ovulation induction. And after initial workup, can you monitor OI cycles without ultrasound? Yes. Progesterone after 20 to 25 days of starting ovulation induction will tell you that she has ovulated or not. So you don't need ultrasound monitoring for all these women. So please do not put them to so much of monitoring where you monitor and then you look at the endometrium, you look at the follicle. Maybe one cycle monitoring with ultrasound is important to see that all is in place, and then you can leave them alone. Otherwise, you can simply monitor with serum progesterone. I do this for all my outstation patients. I tell them to have a progesterone, and if the progesterone is more than 2 or 3, then I know she is ovulated. I tell them to repeat the same for the next 3 cycles. And I'll tell you, 50% of the patients come back giving me the information that they are pregnant. So gonadotropins, as I told you, second line, first line is letrozole, second is clomiphene with or without metformin and gonadotropin. So gonadotropin alone could be used over gonadotropin combined with clomiphene citrate or letrozole in women with PCOS who are anovulatory and infertile and have clomiphene citrate resistance or failure, and no other infertility factors. Please remember that if you combine gonadotropin with clomiphene, the patient might hyper-respond. So it is better to give gonadotropin alone because you will be able to monitor and control the dose very closely. Whereas if you've given clomiphene already for the first 5 days and you've started gonadotropin, when she starts hyper-responding, you will not be able to control it. Another thing is combination of clomiphene and metformin. Instead of giving this, you can straight away go to gonadotropins if she's not ovulated with clomiphene alone, and who is anovulatory, infertile, and probably doesn't have the symptomology in the body like obesity or anything, high blood pressure, or possibly high triglycerides or high cholesterol. So you don't put them with clomiphene and metformin when they've not ovulated with clomiphene. You can go straight to gonadotropins also. This is recommendations of this whole guideline. Then we all know that gonadotropins could be the second line pharmacological therapy for women with PCOS who are anovulatory and infertile with no other infertility factors and who have failed first line oral ovulation induction. Now here when they say first line oral ovulation induction, ideally it is letrozole, but one can try the second line, that is clomiphene, and then move on to gonadotropin. Now, following should be considered when gonadotropins are to be prescribed. One is cost of intervention for ovulation induction. You have to make them aware that letrozole and clomiphene are not costly drugs, but gonadotropins are. There should be expertise required for use of gonadotropins for ovulation induction, which means you need to recognize when your patient is getting hyperstimulated and stop the dose there. And intensive ultrasound monitoring is required. So remember that it is only gonadotropins which require ultrasound monitoring in every cycle. For clomiphene and letrozole, one cycle ultrasound monitoring to see all is in place and ovulation has happened, then you don't need to do it again. And the best is a low dose step up gonadotropin protocol should be used to optimize the chance of monofollicular development. And we have to understand the implications of multiple pregnancy. So you start with a dose in PCOS of 50 units. Then after 5 days, you can go up to 62.5. Then after 5 days to 75 units. And then after 5 days to possibly 87.5. So you may take longer to make her ovulate, but this will work better because you will reach the threshold in a very guarded manner, and you will get maybe 2 or 1 or 3 follicles, not more than that. And there is no difference in the clinical efficacy of the available gonadotropin preparations. When I say this, it is recombinant and urinary. But very sadly, I have to say in India, so many urinary gonadotropins are available with very or minimal quality control. So in other countries, when they use HMG, then it is always a very high quality product such as Minopure from Ferring. But we don't use it because it is a expensive one. So having said that, these are the different gonadotropins which are available. You can use HMG, which has FSH-LH in the ratio of 75 to 75. Urinary FSH preparations where FSH is 75 and LH is only one part of it. Highly purified FSH where impurities are less than 5%. And FSH-LH is again in the ratio of 75 and 1. And recombinant FSH filled by mass, 75 IU is equivalent to 5.5 microgram derived from recombinant technology. So nowadays, pen or multi-dose vials are available for all these products. And hence, you can take out the dose as much as you require and give it to patients. Pen device is very easy for the patient to use because she can set the dose which you have told on the pen and go on injecting it on a daily basis. So this is how do you use gonadotropins and what starting dose, low dose regimen, step up regime, ultrasound monitoring. I'm just re-emphasizing what you read in the guidelines. And these regimens fulfill 2 essential requirements for successful ovulation induction. One is allow slow rise of serum FSH to just reach above the FSH threshold, which is quite high in PCOS sometimes. And it avoids explosive ovarian response because of extreme sensitivity of follicles to exogenous gonadotropin. Having said that, management with FSH or HMG, whatever you are using, in a patient who did not ovulate with letrozole 2.5 and 5 milligram and CC 50 and 100 milligram. So you start with FSH, whatever you are using, a small dose as low as 50 to a high dose of 75 IU a day from day 3 for 5 days. So you've given this, you've seen the baseline ultrasound is a must to see that the endometrium is shed off completely and you know that this is a PCOS ovary. Then you've started stimulation on day 3 or day 4 or day 5, doesn't matter. After 5 days of giving gonadotropin, you will call them on 6th day of stimulation. It may be the 8th day of the cycle or 10th day of the cycle, doesn't matter. When you see the endometrium has started to grow and one follicle is growing more than the others. You continue injection FSH in the same dose, don't increase it, and repeat ultrasound every alternate day till dominant follicle has reached 15 mm to prevent hyperresponse. That is when you stop the gonadotropin and wait for the ovulation to follow. You may or may not give HCG. It is not mandatory. Ovulation will happen. Now, suppose you are giving this, and in cases who have not responded to the earlier one, you went on increasing your dose and you did not get a ovulatory response. What did you do? You did the same thing. You started on day 3, supposedly, of menses. Baseline ET ovary was normal. Day 6, you find that, all the follicles are there and the endometrium is growing, but there's no follicle which is emerging. After 2 to 3 days, you are going on doing ultrasounds, calling the patient, you're giving the drug for 3 or 4 days, again giving the drug for 3 or 4 days, and then 18 to 25 days of incremental doses in 25 units to 50 IU of FSH. If you still get no increase in follicle size or in E2 levels, I like to do E2 levels because that gives me a very clear-cut indication, because E2 levels start rising before the follicle shows growth. Think that this is resistant PCOS, which means 20 days of gonadotropin, where you've given 5 days of maybe 50 units, 5 days of 75 units, 5 units, 5 days of 100, then 5 days of 150, and still you've not got a dominant follicle, I start getting worried. And the E2 levels also don't grow. So what do? This is that little group of resistant PCOS, which is anovulatory PCOS. On oral OI started with 50 units um, of recombinant FSH, got incremental doses of 25 to 50 units of recombinant FSH every 5 days for more than 25 days. But neither there's increase in follicle size, it's only the cohort becoming bigger and bigger, means you have all follicles of around 10 mm, and the E2 levels have not really risen. And problems encountered in these cycles are follicles do not increase in size, nor does the E2 level, but the cohort starts becoming bigger and bigger. Endometrium continues to be low. Sometimes there is intermittent bleeding also. And you've given injections from 18 to 25 days. Say in the next cycle, you start with a higher dose and you go up. Still nothing happens. And then when you really jump up the dose to 225, or add LH to your dose, there is hyper response. And when there is hyper response, you will always tell the patient, don't have sexual contact. Please let this cycle go, because we don't want OHSS, and you don't give HCG also because you don't want OHSS. And if you don't get HCG with multiple follicles there, then in any case, LH surge cannot support pregnancy, and hence a pregnancy doesn't happen. So challenges in PCOS: respond to small or standard doses of oral ovulation induction. Then there is an exaggerated response to clomiphene citrate. And I'll tell you, I gave 100 milligrams to a patient once. And I was very fond of using clomiphene citrate 4 or 5 years ago as even my first line treatment. And she came up, she got pregnant on her own, sent her away, and she came up with 5 sacs in her uterus, and we had to abort her straight away. So this could be an exaggerated response to CC. So I have learned my lesson that don't give more than 50 milligrams. Third group is where they've not responded to both these treatment. You've given letrozole full dose, CC full dose, no response. Then these girls go on to FSH and they respond or hyper respond to small or even small incremental doses of FSH. And you are happy with these patients because in 10, 12, 14 days, you have seen a response. You've seen follicles coming over 14, 15, and you can probably stop your gonadotropin at 15 mm size. Before that, I have had so many cycles where the E2 dropped and the follicles stopped growing. Then there is resistance to incremental doses of FSH. And the last is that they hyper respond to only high doses of FSH or HMG. So the challenge is there exists a definite group of anovulatory PCOS who appear to be resistant to ovulation induction when treated with small incremental doses of FSH over time for the purpose of ovulation induction. So we thought, is it let's see what is the factor common in these group of patients. Is it high AMH? Is it the obesity or high BMI? Is it high LH or high androgens? So we did a study, and this was published in Journal of Fertilization in Vitro IVF Worldwide, Reproductive Medicine, Genetics, and Stem Cell Biology. This was a series of 18 cases of clomiphene-resistant and ovulatory women with PCOS and altered response to FSH stimulation. When I wrote altered, it meant that they did not respond to FSH stimulation. Those who responded, we just had to give them a very low dose and they did ovulate. And if you see, I already told you how we treated this. We jumped up to 225 and then got an explosive response to ovulation. The common factor in all these patients was high BMI and high AMH. This is in picomoles. We do our AMH in picomoles, but if we convert this into nanograms, then this would account to about 13 or 14 nanograms, which is very high AMH. So these two factors were common. If you see LH, it was not high, the standard deviation. If you see ovarian volume, antral follicle count, it was not high. So it was not anything else, and all were hyperandrogenic. All had hirsutism, various degrees of hirsutism. So all these women, 18 women, had a lot of hirsutism. So what we thought, why some PCOS respond to exogenous FSH when administered in appropriate doses of OI. That means, why don't some PCOS respond? It is possible action of AMH, or there is a polymorphism of the FSHR serine 680 variant is high in hyporesponders, and therefore consumption of FSH is higher in carriers of this polymorphism. And we've seen very high AMH has an inhibitory effect on follicular recruitment, especially on low dose step-up FSH administration. And if there is FSH receptor polymorphism, the FSHR serine 680 variant, then follicles are resistant to lower doses of FSH. This doesn't go and fit into the receptor very well. And when we give high doses, then only we can overcome this receptor polymorphism. So this is in fact good news for IVF clinicians, because if you have this problem repeatedly in ovulation induction or stimulation, and you refer them for IVF, then these girls, whether they have very high AMH or FSH receptor polymorphism or 5-beta LH gene mutation, whatever it is overcome by high starting doses of FSH or HMG, as we do in IVF. When you are inducing ovulation, you would start such a high AMH patient with 50 units of gonadotropin. And in 2 cycles, you will learn your lesson. Oh my goodness, this is like somewhere she has one of these things, and that is why she is not responding unless I give her high doses, and then she has an explosion. So here in IVF, you will never start with 50 units. You will start with 150 units. And that 150 units overcomes this AMH dominance or polymorphism much faster. So what is a tiered approach to ovulation induction? Well, lifestyle changes with diet and physical activity, especially in overweight women, is very important in all PCOS, in all steps of ovulation induction. And you can add or not add metformin according to what your patient is like, what her profile is like. If she's going towards metabolic syndrome and her family history is there, she is overweight, you can start metformin with lifestyle changes. And step 1 is letrozole. As I told you, you start with 2.5 milligram, 5 days, identify ovulation by ultrasound first cycle, and you know which day she's ovulated. Please continue the same cycle for 3 cycles with no monitoring. I am a person who's very fond of doing PCTs also, because a patient's husband may have an absolutely normal semen analysis. The frequency of sexual intercourse has become so low in today's generation that they hardly have sexual intercourse. And because of that, they have some degree of vaginismus, and therefore deep penetration or complete penetration does not happen on intercourse. And hence, one postcoital test in the first cycle when I'm monitoring reassures me that yes, their intercourse is proper. Just leave them for 3 cycles with no monitoring. She gets her menses, means she's not pregnant. If she doesn't get her menses, goes over by 3-4 days, please ask her to do a UPT or a beta HCG. If there's no ovulation in the first cycle, then you increase the dose to 5 milligram, identify ovulation with this, and then give her 3 cycles. Now, suppose there's been no ovulation in both these things. So the step 2 is, I told you, the second level of treatment is Clomiphene Citrate. Well, I've written 100 milligrams, but you can start with 50 milligrams for 5 days, confirm ovulation, and repeat treatment for 3 to 6 cycles. 6 cycles is saying too much, but yes, Clomiphene in a lifetime should not be given for more than 12 cycles and never more than 3 to 4 cycles in a go. And if you want better response, add metformin for better response or to improve metabolic syndrome. So maximum dose of clomiphene is 100 milligram, and you can start with this dose in women who've not been able to ovulate with 5 milligram of letrozole with or without metformin. Then the third step in the level 2 treatment is you go on to gonadotropin. So within 3 or 4 cycles, you have known that she's not ovulating with letrozole, she is not ovulating with clomiphene, then you move up to gonadotropin. And gonadotropin 150 to 75 IU with ultrasound. I'm sorry about the mistyping. It is 50 to 75 IU with ultrasound follicle monitoring with slow and small increments, like I told you, is mostly enough for ovulation in 75 to 80% of patients. Serum E2 levels for me are very good guide to prevent hyperstimulation. Then we come to the next step. This is the escalated gonadotropin, where you have to escalate to high doses due to resistance or to resistance to smaller doses. And if there is a multifollicular response, you find 4-5 follicles of 17-18 millimeter, please avoid pregnancy, stop them from having intercourse. And the last one is IVF with antagonist protocol with agonist trigger. If you get more than 50 oocytes or E2 is more than 2000, at trigger, freeze all and do a subsequent frozen embryo transfer. Fresh ET, if you have less than 15 oocytes, lower E2, and the patient has no symptoms of pain in lower abdomen on day 5 when you call her for a blastocyst transfer. If she has it, please postpone the transfer to a frozen embryo transfer cycle and freeze all her embryos. Last is IVM is the last resort in women who don't ovulate with any drug. They just go on making a bigger and bigger cohort, nothing ovulates. Drilling is an option when gonadotropin treatment is not possible due to personal reasons. Now, it is not this that drilling is a very cheap option. It is an invasive, it is a surgical option. But yes, a lot of women after giving letrozole and clomiphene say that, we can't come for monitoring. So you can probably drill them, especially if there is another indication also for doing a laparoscopy, like a small dermoid cyst or maybe endometriosis also. So you can just go in with the laparoscopy. And in endometriotic cyst, if it is truly a endometriosis, please don't drill them. Just remove the cyst if it is a unilateral cyst and drill the other ovary. If both the cysts have endometriosis, just fulgurate the ovarian spot of endometriosis and leave her. It will work as much as drilling works, almost. And hence you will not lead to a low sort of a ovarian reserve for her. The last word to ovulation induction, if the diagnosis is correct, most cases will ovulate. It's hardly 1 in 1,000 who do not ovulate despite high and low doses. Aim is not to achieve ovulation at the cost of increase in complications. Because if you achieve a triplet or a quadruplet pregnancy, it is not success. You will need to do fetal reduction or have to abort this pregnancy. Days taken to ovulate do not matter. So 20 days, 30 days do not matter at all. Ovulation induction is not only a science, but a piece of art. Thank you. So we have enough time for question answers, and I would be happy if we could have question answers.
Ma'am, thank you for such a comprehensive and practical talk with so many take-home points. Ma'am, starting with the questions, Dr. Asima wants to ask, what's the maximum dose of gonadotropins that you've used for these patients for ovulation induction?
Generally 225 international units, very rarely 300. In any case, I never use more than 300 units of gonadotropin in any case, whether it is a poor responder, whether she belongs to the polymorphic group or she belongs to PCOS. So 225 is the highest dose I've used for these patients. I'll have to go through this study. I think I've used 300 also in a few patients, but never more than that.
Ma'am, Dr. Basima wants to know, will you give extended letrozole before shifting to gonadotropin?
Basima, I am talking about evidence-based practices. I've taken into account there are a lot of combinations, permutations. We have human brain is very fertile. We will go on thinking of different methods of achieving our goal. So these are methods which have been described in some studies by some workers, but they have not universally been accepted. So I don't use extended letrozole.
Dr. Shipra wants to ask, sometimes in PCO, when we do ovulation induction with gonadotropins, we do get 2 to 3 follicles, but endometrium is just around 6 to 7, and that too not trilaminar. How do we approach?
You tell them, you or Tejashree answer this question. What do you do? 6 or 7 is not bad.
Is good enough. Yes, we'll go ahead.
You just go ahead and this endometrium catches on its own. Don't have to add any drug over here.
Ma'am, Dr. Karuna wants to know, a young girl with
Who
PCO.
was having a lot of messages about voice and video issues? I can hear very well, see very
Yeah,
well.
actually, I was getting a lot of messages, ma'am, that we are not able to see the
Oh,
video or not able to listen to
it
the
must be
voice or
their
not able to
internet. If you were
join.
being able to see.
Yeah, so I have throughout been able to see you and listen to you.
Yeah, so maybe it was their internet which was not very good. That's why they were having video and voice issues. I'm sorry about it. Well, this topic will go on the website within a few days. I hope my moderators chase the organizers and they send us a video for this fast.
Yes, ma'am. Dr. Karuna is asking, a young girl with PCO morphology with high FSH and LH above 25 and AMH of 8 nanogram, no response to gonadotropin 150 IU for ovulation induction.
Very nice, Karuna. You can do nothing for her. Either you do IVM or you take a donor egg, because this is probably FSH receptor resistance. That FSH is above 25. AMH is very high because she is a PCOS, but PCOS can have FSH receptor resistance. I've had such a case, and that was a learning case for me, that your FSH is above 25. I don't know how much it is. Mine was like above 40, 50 when I went on repeating it without any OC pills. And you cannot stimulate these because you cannot take the FSH threshold to above a level which is as high as 25, which is considered POI. You will not have any response. So Karuna, please be careful. Withdraw all her medicines, do a repeat FSH, LH, don't look at her AMH, and and E2 also. And if her FSH is high, E2 is low, then you will not be able to make her respond with gonadotropins.
Ma'am, regarding increasing the dose of letrozole from 2.5 to 5, you don't seem to prefer that too much, as we see a lot of cases of breakthrough bleeding. Ma'am, what's your opinion on that? Should we increase the dose or should we shift to a clomiphene if we don't get?
I'll tell you, Bhavani, I've of late realized if I've given letrozole to a patient with low reserve, say in a patient whom I'm going to do frozen embryo transfer, the breakthrough bleeding is more over there.
Okay.
And even in PCOS, I've had breakthrough bleeding because colleagues told me, oh, give 5 milligram, it's very good. But I have seen, I wouldn't say in all cases, but in maybe 20%, or how much have you seen, Bhavani, when you worked with me?
Yes, sir, maybe around 10%, 10, 15,
10%, yeah.
10%.
10% of patients do have a breakthrough bleeding, and this is because E2 levels remain quite low for some time with letrozole, and they go below the menstrual threshold, and hence there is intermittent bleeding also.
Dr. Nisha Vaidya wants to know that do you bring down LH before ovulation induction in these
Why
days?
don't you answer this question? What do you do? Because
No, we
Tejasvi
don't.
and Bhavani have worked with me, and we all follow generally the same principles. Yes, one evolves with time and changes their protocols sometimes. What do you do?
No, ma'am, we
don't try
don't lower
to,
down the LH.
So
we
you
don't,
don't
LH
need to
hyper,
lower down. Yeah.
yeah, we
The
come
moment,
across a lot of LH hypersecretors, but there is no need to bring the LH down before we stimulate. The response remains the same either ways.
yeah. Any role of ovarian drilling in such a case? You can try. Maybe Karuna, this is a very good food for thought that if we can drill, bring her AMH down, but it looks like FSH receptor resistance. What do you all think? There are
Ma'am,
so
how
many
would it
people.
help in a receptor polymorphism?
Yeah,
Drilling
not
will not
polymorphism. This is resistant receptor.
resistance. Yeah, this is totally a resistant, I mean, FSH
Everybody else's
resistance.
opinion. There are so many seniors. Anyone's opinion. What can you do for this case? Which Karuna has asked, because I couldn't do anything for her. And at last, I did oocyte donation from a sister's egg to her and did IVF.
Ma'am, anywhere where there is a receptor polymorphism, it is said that higher dose is the answer. So,
Yeah, polymorphism, yes, but not in receptor resistance.
okay. Mhm.
There is a difference in receptor resistance and polymorphism. Polymorphism may be always increase the dose, add LH, do both the things.
So, ma'am, you feel that if FSH is more than 25, it is more towards resistance than polymorphism. If it would,
It is resistance only. POI की definition,
हाँ,
all the
अगर
guidelines.
polymorphism होता तो 10 to 15 के बीच में हो सकता था.
Yes, और 15 to 20 भी हो जाता, पर
हाँ.
25 के ऊपर 2 occasions 4 to 6 weeks apart stamps the diagnosis of resistance, because I wouldn't say this is POI because the AMH is so high, right? If it was
Yes.
POI, the AMH also would be very, very low. The FSH would be high, the E2 would be low. But
Yes, ma'am.
AMH is not really considered as a parameter to diagnose POI these days, because they look at ovaries, their volume, and AFC, and they look at FSH and maybe E2 also.
Dr. Basima wants to know that will you use LH along with FSH in IVF stimulation for PCOS?
I don't use anything. I'm the most simplified stimulation, just FSH. What do you all use? Tell us.
Ma'am, in cases where we are seeing a poor response by day 6, if we have, started her
Yes.
with a good dose, and if we see
Yeah.
that she is not responding the way we expected, maybe we can add a little LH
Excellent.
in those
This is a
cases.
very good answer, that we don't start with LH in PCOS, which we start in patients who have a low reserve or like a poor ovarian reserve. But as Tejashree said, you can rescue a cycle if you find that LH is low on day 6 of stimulation and add LH to her. If
Ma'am,
LH
on
is
that
high, would you
note,
still add? If LH is 5, 6, would you still add LH? I'm just asking because even I have these queries always in mind. When the case sheets come to me, then I keep thinking, should I add LH? It is good to add
ma'am,
LH, I think.
and there are cases of PCOS where we've seen that recombinant FSH just doesn't work, and when we
Yeah,
shift to
HMG
Humog, where
works.
it HMG, it does work. So I'm still, in a question always that which are those patients who require Humog, and you only
One,
know when the
when it
HMG,
goes wrong. You are right.
yeah,
So, two
yeah.
5 days of stimulation, you find that the E2 levels have not risen, the response is poor, then maybe we
Mm.
can add LH. Yeah. Whichever way, whether it is urinary or recombinant, doesn't matter.
So, can we add LH in the form of HCG, ma'am? low dose HCG.
A lot of people do like to add, like you have nano HCG available and you can add small doses, but I have no experience with it. You tell us, how much do you add? You tell us,
Not
what do
really
you
used.
add? Anyone who adds HCG and who's very confident, don't tell us just what you've read. If you've done, tell us, and we will try that treatment, because these classes are that we get everyone's opinion, and those who are really doing well in their IVF cycles, I want to know whether HCG. Anyone, Tejashree, have you added ever HCG nano doses?
No, ma'am, not in a stimulation
And
cycle.
anyone else?
I have used it, ma'am, but not in PCO patients. So I
Mm,
have added it in normal responders as well as for the low ones. And
okay.
it is only to be
How
added
much dose
after
and when do you start?
I'd add usually 150 to 200, and
Mm,
that too after 5 or 6 days, when the
okay.
level of the size of the follicle is, say, 10 plus. The some receptors are already there on which they can respond. Only then
So
do we
this
add.
is this is a food for thought, because a lot of articles say that you can add HCG, and a lot of proponents are there of HCG. The LH makers say that receptors are LH receptors, so HCG doesn't act very well. And two, HCG has a long half-life, so it goes on accumulating on the LH receptors, and hence when you give a daily dose, it has no receptors free to act. So both have their own theories. The HCG proponents say that you give small doses of HCG and it stimulates follicular growth. The LH promoters say that HCG is a long-acting drug, so it is pro-apoptosis, because the receptors go on getting down-regulated. So there are no receptors where you give a daily HCG to
But
act.
definitely there is not apoptosis, ma'am. It does increase. It does give response.
No, no,
Apoptosis to
no.
nahi hoti at least.
Not apoptosis in that sense, follicular. They say that the receptors get attached on the cells, the granulosa cells, where they have to get attached to the LH receptors. And the LH receptors are occupied. So the LH receptors are, I would say a better word, down-regulated with HCG. This is
Okay.
what the
Mhm.
प्रोपोनेंट्स ऑफ एचसीजी से, एंड एलएच वाले बोलते हैं एलएच तो कुछ घंटों में निकल जाता है, तो नेक्स्ट डे अगेन इट इज रेडी टू टेक अनदर डोज ऑफ एलएच. सो you have to really do very nice studies, compare these two group of patients, and then we can say that yes, this is better. I have never had the himmat of giving anything else. So it has either been FSH or it has been LH in the form of HMG or LH as such.
Thank you.
Ashima says LH is already high in PCOS, but you know what? The intrinsic ovarian cycle is used to a high LH. So you have to increase LH. And once the FSH is given, if you see on day 6, 7, you will find LH is going down and the follicles are coming up. So LH is naturally down-regulated in cases where you start stimulating them for IVF with good doses of FSH.
Dr.
Ma'am,
Chipra
many a
wants.
times, sorry,
Yeah,
yeah,
yeah.
Dr.
Say.
Bhavani, you want to go ahead with the question? So basically, ma'am, I just wanted to ask a question wherein we have a lot of cases. We give, just for the benefit of our listeners, that we give letrozole and we call the patient on day 12. So if we've given
Yes,
2.5 for 5 days and we call them by day 11, 12 to see whether there is any follicle which is more than
right.
12.
Yeah.
If there is no follicle which is, not even 10. So in those cycles also we do add little gonadotropin and take those cycles forward. So I
Yeah, yeah.
think that
We
is
do
also
that.
something.
We do that. And very recently in one cycle, uh,
Hmm.
Swati was with me and she said, ma'am, day 12, there was absolutely no response, no endometrium, no follicle. I gave her 3 doses of 50 units of Folisurge. When the patient came back, we had an explosion on her on her ultrasound of the ovary. So, they can really hyper respond at times. So be careful, give it. I have
Yeah.
also given, and I don't say don't give, but sometimes you get an explosive response. Today, one case was there. We were preparing her for FET. She was on letrozole. So Tanu gave her FSH for 2 or 3 days, and she gave her only 50 units. Now the patient, and we told her, come after 5 days. By this time, you'll make something. She came, her E2 came rolling down to 30. from 80 where it had gone with the gonadotropin, because we saw follicles of 14, 15. We said, और नहीं देंगे, नहीं तो explosive response होगा, we'll have to cancel a FET cycle. We say you come back after 3 days, possibly these follicles will grow. Nothing grew. And her E2 came rolling down to 30, but her endometrium was 7.5. This was a big dilemma in my mind. I told her we can't give her trigger at a E2 of 30, even though the follicle is, how much it was, 14, 15, which we've read that we can give, but E2 is too low. She said, let me convert it into HRT cycle, give her progesterone. Endometrium has become 7.5. We'll give her little progenova. Somehow I didn't know what to do. I was in a dilemma. I wish I had a Ramban to know what to do, but I told, let us give her 2 more days of polysurge, 3, and then call her on the 3rd day, because her E2 has gone so down low that probably all the follicles are just
Follicles have become non-functional, yeah, and they
non-functional.
will not support the endometrium. They may
Will
not
not
even
support
convert into
them.
a corpuscle. Yeah.
So I told the girl that if this time anything happens, maybe you bleed, maybe the E2 doesn't rise, if the follicles don't grow, I'll cancel the cycle.
Though this was a very sudden drop and a gross drop in E2, but letrozole cycles, we do have E2 levels which are low.
We
So
इसलिए
that's also a caution point.
yeah, we don't do E2 in letrozole cycles.
Letrozole
The
cycles.
only we did in the baseline was 30. And then when she came on day 12, when we gave her 3 days of polysurge 50,
She had a higher
had
rate.
gone to 80. So we said, okay, it's okay. And the follicles are 14. So let's leave it here. They will grow because they might grow. She came back after 3 days with the E2 of 30, endometrium 7.5, and the follicles static where they were.
So every case of PCOS surprises us
Yes,
and tests our knowledge.
correct.
So
Ma'am,
PCOS, I think, is something
could
which is
I
tough.
also talk? Could I
Please,
also talk?
please,
Yes,
please.
ma'am.
Who's this guy? Let
Ma'am,
me
this
know
is
the name.
Shipra. Good evening,
Shipra.
ma'am.
Come on, Shipra. Yes, please.
So, ma'am, I have a patient. She's 30 years old. She has a AMH of 14 nanogram, and I have given her ovulation induction. She just did respond with the gonadotropins. I ended up making 3 follicles, ma'am. And before that, I was also monitoring her with the ovulagens. Every time, what I saw was that endometrium was lacking, like
Mm.
5, 5.5, maybe 6, maybe 6.2. But I could never see the
Never mind.
trilaminating.
Tell her to try for pregnancy. Don't run after the endometrium. Have you not seen in the literature reported endometrium of less than 5 also supporting a pregnancy? And this is a natural endometrium being formed on endogenous estrogen, whatever she's making. So you can check her E2 levels, and if the estrogen levels are good, you don't need to do anything. Endometrium of 6 or 6.5 or 7, all will support a pregnancy. Please do not run after the endometrium if she's had no injury to the endometrium in form of infection or surgery before.
All right, ma'am. So now we have, right now I'm just stimulating her for the IVF, ma'am. And I'll
Please
let
do
you know
not.
about.
Please do not. Have you given her a trigger and told her to get pregnant on her own, or done a IUI for her?
Yes, ma'am. So I have done approximately 6 cycles of,
Oh, then it's all right.
yeah,
Then it's.
yes. So yeah, so I'll let you know, ma'am. I'll follow
But
up with the place
you
with
were
you.
not going to go for IVF only because you think that IVF will lead to a better endometrium. If she's
No, no, ma'am. No,
uh,
ma'am. Actually, she's been trying for 2 years and then,
right, and
yeah,
she's ovulated and she's had
yeah,
contact successfully and
yes,
nothing.
ma'am. I have done an IUI, 2 cycles of IUI also with her, ma'am.
Now
So
I'll
the
tell you
issue,
one thing. In IVF, when you are stimulating her, you'll make more follicles, right? You may
yes,
not
ma'am.
get 12. Look at her endometrium then and take that
Yes,
as
ma'am.
a standard endometrium, whether it is 6 or it is 7 or 6.5. And then aim to reach that endometrium without HRT. Just go on a cycle, whichever you thought was better, whether it was letrozole or
Mm-hmm.
gonadotropin,
Mm-hmm.
small doses, which led to a ovulatory follicle and which led to a endometrium of 6 in your cases.
All
And
right,
her
ma'am.
transfer accordingly. But look at her endometrium in the cycle where you've stimulated before you give the trigger on the trigger day.
Yes, ma'am. Thank you so much, ma'am. Thank you very much.
Ma'am, again, just a question regarding the non-IVF consultants that they would, have in their mind. That if you are giving a oral ovulation induction with letrozole or cyphine, and she makes a dominant follicle, would you prefer to give a trigger, or
No,
would you prefer to just leave her alone
no trigger.
once you see that a dominant follicle has reached
No
18 to
trigger. A
20?
spontaneous LH surge can hold 1 to 2 follicles and 1 or 2 ovulatory follicles very well in the luteal phase without causing luteolysis or without letting the endometrium get bad. If there are more than 2 follicles, like all the guidelines say 2 follicles should be the maximum in IUI. But in IUI, we give a trigger to time our IUI. In natural ovulation cycles with clomiphene and letrozole, you need no trigger. No trigger means no trigger. And that is how you can leave them for 3, 4 cycles with the same drug, trying to conceive on their own without ultrasound monitoring.
So that's what we do. In
Mm.
case we are seeing the patient for the first time, we give her ovulation induction, see a dominant follicle. We just leave her
You can
alone,
let it ovulate. Yeah, let her ovulate on her own.
and then we don't even call her back for the next 2-3 months. We just ask her to take the medicine for 5 days initial, and then try naturally for the next 2 or 3 cycles. We don't need to call them every month. And a regular cycle would then confirm that she's ovulating. So if she's not conceiving but getting her cycles 28 to 35 days, then she's probably the drug is working
Very
in the form of
accurate.
ovulation.
Very accurate. And first cycle, when you monitor, you know her approximate. Like today also, there was a patient, exactly same what we are talking. She is PCOS. She got married. When she started trying, within 3 months, she was taken for IVF. 2 IVF cycles failed in Gurgaon somewhere. And then she came back to me and I said, have you tried? And she said, no, we just tried for 3 months, but my cycles are regular. So I did a serum progesterone on day 18. She had come to me then. The progesterone was still less than 1. I was not sure whether she was really ovulating and her cycles were 28 days. So this time I gave her letrozole. She ovulated, or she came with a dominant follicle around day 16. She may take 4 more days to ovulation. So I told her that your fertile period is probably from day 12, 13 to day 22. You understand? So their fertile period shifts forward. They should not stop. आजकल तो वो button की तरह intercourse होता है ना, that you tell them this is the fertile period, they will have intercourse then, and then they stop having. So just tell them that the fertile period has extended from day 13 to day 23. Please try more frequently. And I think it will work for her. I'll be very happy if she gets pregnant, and I will share it with everyone, because she said that we have never truly tried intercourse like that. We've just had, in the fertile period, which is day 10 to day 16, and she's never ovulated, possibly, at that time.
But then, ma'am, is there is any harm in triggering if the follicle has reached that size?
Why will you call her for ultrasound every cycle? The whole aim of causing ovulation induction is lost if she has to come to your clinic every cycle with that tension. आज intercourse होना है, आज trigger मिला है, मुझे आज कल परसों होना है. Just leave her alone and give her a broad fertile period of 7-8 days. If you've monitored her in 1 or maybe 2 cycles after giving her letrozole and you find everything looks okay, but a dominant follicle is sitting there on the 16th day without the surge happening, instead of doing a daily surge like we do in FET cycles, you can just leave her alone. Tell her do a progesterone on day 20 or 22, and you'll know when did she ovulate.
Thank you.
Ma'am, what
Ma'am,
is
may I ask one question?
Yeah, I couldn't hear. What did you ask?
Ma'am, this is Dr. Nisha this side.
Yeah.
Sorry to interrupt. Ma'am,
No, not
just
interrupt.
like,
I want you all
no,
to.
actually somebody was speaking and I just intervened. I don't know, Dr. Tejashri was speaking. So ma'am, just like Dr. Shipra's case, no, I mean, I also had a patient. I mean, she never responded to oral letrozoles. So like we converted her to gonadotropin only cycle. But ma'am, somehow the endometrium would reach 6, but the patient would every time had a breakthrough bleed. I mean, she would
Yeah.
start bleeding for 2 days, and then even she would get so perplexed ki whether we should be trying intercourse or not. I mean, although we might land up with only 1 follicle, because I used to start with 37.5, but although the
Did
patient
you
has
ever
lost
check her
follow-up,
estradiol
but
level? Did you ever check her estradiol level when she started bleeding?
No, that I haven't,
Please
ma'am.
do that next cycle. And you know what happens if you give very low doses? Maybe a follicle which has grown is truly not a follicle. So this breakthrough bleeding is very common when we give gonadotropin, stop at 14 mm in resistant PCOS, and then we think, oh, अब follicles बढ़ जाएंगे, अब तो दिख रहे हैं बहुत. And then she comes down with the E2 going down, bleeding starting, and no follicle have grown. So possibly this is the same because you gave really a small dose,
So,
37.5.
ma'am, the remedy is like even in
In
such cases, like 14 also, we
yeah,
should keep on feeding for another 2-3
you
days.
know, with experience, I think, Dr. Nisha, in such cases, in fact, you can do a step down. You start with a higher dose. Maybe you'll have
Okay.
more follicles, good E2, and then you
Hmm.
step down so that you support just 1 or 2 follicles then, which would
Right,
be
right.
useful for
Try
fertilization. But
and
the
see, you
E2
will not
remains
have the
high.
breakthrough.
Ma'am, actually, our
You
AMH
will
is
not have a
24,
break.
so stepping
Yeah,
down.
is
Yeah, it is
dangerous. We
scary, but
understand.
step down will help you certainly because once
So
you
if you
step
give
down, only 1
100
or 2 will go.
units, if you give 75 units for 5 days and you find lot of follicles coming up, 14, 15, then you make it not half, but you make it 50. If you make it half, फिर तुमको bleeding हो जाएगा patient को. I've seen that happening. आधा किया नहीं कि बिल्कुल सब कुछ गायब
Yeah.
हो जाए. So
Hmm.
थोड़ा घटाओ और या ये करो और या फिर अपने E2 levels देखो. Monitor
Right,
करो
right,
जब
right,
follicles
ma'am.
17 है, what are the E2 levels? Okay?
Okay, okay, ma'am.
Ma'am,
Let's
Thank you.
try
lastly,
and
what
see.
is your take on the luteal phase support in these PCOS patients where we are probably stimulating only, I mean, only trying to induce with oral ovulations? Would you
Nothing,
still
nothing.
want to do a
When
luteal
you're
phase
giving
support?
oral, you don't need trigger, you don't need luteal phase support. When you're using gonadotropin, and especially if there are more than 2 follicles, 2 dominant and 1 or 2 smaller ones, which are contributing to estrogen, then probably giving luteal progesterone becomes important.
This is, I think, a very important take home for all the gynecologists who are using oral ovulagens that, you just leave her alone because you might be prematurely giving HCG, which may not be, which might cause more harm than benefit.
Very important point, Tejashri, because in
Yeah.
oral ovulogens, we want the follicle to grow to 22, 23, 24 millimeter also. And we all have a tendency to give a trigger at 18, 19, 20. Don't do that. In IVF, it doesn't matter, but in normal ovulation induction, it matters.
Yeah. So no HCG, no luteal phase support, probably for the first 3 cycles, if that's the beginning point that you are starting the treatment.
Please do this. Take my word, it will work for you. It will work for your patients. And when you go on gonadotropin, monitoring is very important. Trigger is important because HCG will support the luteal phase. That is why trigger is very important because you may be having 2 or maybe 3 dominant follicles also. But if you have one dominant, you can leave her.
Ma'am, what is your take on converting the hyperstimulated cases to IVF?
Very difficult to convince a patient at that point that तुम hyperstimulate हो गए हो तो IVF में चले जाओ because it is a big decision, cost implication, everything. I have found it very difficult to convert. Where when I was reading William Omlet's WHO thing 2018, that what they do in these hyperstimulated women, you don't convert them to IVF, but you take them to the IVF lab. You aspirate all follicles, leave 1 or 2 big follicles there and tell them to go have intercourse or do IUI. This is what they do. This is a GPP, good practice point, where you can aspirate all. You will avoid multiple pregnancy, but you may not be able to avoid OHSS in such cases. And you can convert them to IVF if your patient gets easily converted. Mine don't. Very difficult to convert. At that point, we can tell them for the next cycle that, see, you always hyper respond when we increase the dose. So maybe IVF is a better choice for you. And that I've done for a lot of patients. You give them slow gonadotropin, you give them for 25 to 30 days. There's a patient who's still coming to me for a second IUI. Told, I don't know what to do. 25, 30 days you made follicles and that also you exploded. And we had to tell you, don't have intercourse. And in any case, we didn't give any trigger. We didn't do anything. We didn't tell them don't have intercourse because it would have been very hurtful for them. But we knew that if we are not giving HCG, then the luteal phase will die away because there were many follicles. So we just said, okay, do what you want. And she came back pregnant. नहीं हुई हमें मालूम था कभी नहीं होएगी pregnant.
Ma'am, last thing, this is also very not very rare thing, but this is does happen in IVF cases also, where we might have to give a high dose for a long time.
Yeah.
Kanika was a patient where we gave her 300 despite her AMH being 4 nanograms, and she required almost a stimulation of, I think, 15 days, and that's when we crossed
Don't
her threshold.
hesitate in giving longer stimulation. This is what I would say. We always looked into articles which said stimulation less than 7 days and more than.
So Adi.
So some entertainment in between. I also wanted to bring one thing more to your notice, Tejasri, when you said one more question, which came to my mind very recently. I came through that problem. Anyways, if we remember anything, we will put it on this group. Please try the way the evidence says, and I have tried this and it works very well. And जैसे letrozole में breakthrough bleeding कभी कभी हो जाती है high dose में, even gonadotropin में I feel Dr. Nisha, the breakthrough bleeding may have happened because you were using a very, very low dose of gonadotropin and therefore the estradiol did not rise. Follicle rose, and then if you were using HMG, I'm afraid that batch to batch variability could be there. Bioavailability of the drug varies from 30 to 90%, which is a huge variation. So 37.5 आप दे रही हैं और मेन अगर 2 दिन आपका 20 units chala gaya with that dose written that this is 37.5, activity is equivalent to 20 units only. She will definitely bleed with a dominant follicle sitting there also.
Ma'am, I had a question. In
Yeah.
your long experience, usually on an average, stimulation days are around 10 days, occasionally 11 days. So just now, Dr. Tejri said that, even for 15 days that you have had observed in poor as well as in PCO patients, that minimum this much should be given.
No, you have to wait till the follicle grows. That is all.
That follicle
Because
17,
you
18
want the
size.
oocyte maturity, and oocyte maturity does not depend on the estrogen level. It depends on the follicular size. When the gap junction ceases to happen and the oocyte becomes mature and it is loosened and it can, sort of be taken out by IVF. So sometimes, you have to reach a follicular size of 18 at least or 17 to give a trigger. So अगर 14-15 पे अटके हुए हैं तुम 2-3 दिन और देना ही पड़ेगा इनको. So you segment your cycle if you feel the progesterone levels have gone high on the day of trigger. ऐसी cycles में खाली progesterone कराओ, सब में मत कराओ. And if you find that it is going higher, then you can sort of segment your cycle, freeze all your embryos, and do the transfer in a subsequent cycle.
If in a poor ovarian reserve patient, I have found the follicle size has gone to 17, 18 at day 6 or day 7 only. So should I trigger her at that time and
This
do
is a very interesting question, Anupma. I had gone to Kanpur just now for their workshop. They had a presidential Foxy conference, which is something new which have started. And I showed 2 cases where I started with the E2, baseline E2 was somewhere around 90 or 100. And the follicles were okay. But after 5 days of stimulation, which is on day 7, a follicle was 18, like you said, and the E2 levels had gone up to 200 or 300. And I looked at the LH, and the LH had started rising also. It had gone to 25. I gave her decapeptyl. I did a progesterone after 2 days. It had risen from 0 point something to 1 point. I put her on a PPOS protocol. After that, we took out 8 eggs. I think Bhavani would remember that case. Bhavani?
Yes, ma'am.
Huh?
Converted her to luteal stimulation.
Converted her to PPOS protocol.
PPOS.
So in your case also, if your follicle goes to 16, 17, like you said, and the E2 levels have gone up, that means this follicle, low reserve patient, often select their follicles in the previous luteal phase, say day 25, 26 of the luteal phase. So follicle is growing from then. And therefore, the E2 baseline is on the higher side. And when you stimulate for 5 days, say it is day 7 of the cycle, you will find a follicle fully grown. It's better to let it ovulate because you won't be able to stimulate the cohort here. And then you go to a PPOS protocol, and other patient we've also kept on an antagonist. I saw Dr. Sakshi's patient that day, and it was interesting to see she didn't bother about the LH surge. She went on stimulating, and this was a random stimulation. So she gave antagonist according to the LH levels after 5 days of stimulation. So you can do either ways, but PPOS is good. I feel that we've reduced one injection and given her a simpler way, and we know that in this cycle we cannot do a transfer.
Since I had added citrulix in this patient, she would not be ovulating now. I
You do
started
a LH.
citrulix on day 3.
Okay. No, you added
On day
cetrorelix on
3, I've added.
day 3.
Day 3,
A
yeah.
lot of people like to give antagonist for first 3 days, not day 3, day 1, 2, 3, and then start their ovulation induction. This is a new method which is again being revived. एक जमाने में हम लोग करने की सोचते थे, फिर हमें लगा नहीं ये बड़ा नॉन एथिकल होगा. But now I heard in a conference I had gone, कौन थे जिन्होंने बोला था ये LH या estrogen first 3 days में दो? Bhavani, you all heard his lecture? No. I heard, I'd gone to Ahmedabad and I heard his lecture. And he said, when you think that the cohort is not good, give antagonist just for 3 days. It will suppress all the follicles which are growing and it will make the cohort equivalent. And from 4th day, you start gonadotropins. So you've done the same, Anupma. So it's all right. Don't give for 1 day, give it for 3 days then.
Yeah.
You read this article. He's a great publisher. What was his name? I can send his name because I took his first slide and I took his name so that I can go into his work and see what he does.
Dr.
Thank you.
Anupama, I think what you were trying to say is that follicle will not rupture, the one which became dominant. That's what you meant,
Yeah.
right? So don't
Yeah.
bother
No.
about it. You just
She's
go on
saying the
stimulating.
subsequent cycle. Did I understand wrong? You gave
Yes, I was
antagonist.
talking in the same cycle and not the
And-
subsequent.
Acha, you said in the same you gave antagonist.
Yeah.
उस
I
cycle
just
का
stimulated it as a standard antagonist cycle,
Hmm.
but to my surprise, they came up very early, day 7, I was not expecting a size of
LH कितना था
18.
day 7? LH कितना था?
नॉर्मल लेवल पे था, मतलब डे 1 से कम था, डे 1 डे 2 से कम हो गया था, जैसा
अगर LH कम
एक्सपेक्टेड
है
थोड़ा
तो
लो
you
हो
go
जाता.
on stimulating, add antagonist, ignore the other follicle. It won't rupture. It will become cystic till the rest of the cohort grows. But this is a new cohort which you have selected on that day by giving antagonist. You understand?
वो स्टैंडर्ड डिलेमा है मैम, कि वो वालों को चेस करो या जो नए आ रहे हैं उनको पकड़ो या पहले वाले दोनों को
उसको
पकड़ो.
चेस
दैट
करोगे
वाज
तो
द
एक ही
प्रॉब्लम.
फॉलिकल, उसको चेस
दोनों में
करोगे.
ही दो थे
हम्म
मैम. जो आ रहे थे वो भी 2 थे और जो
हम्म,
पीछे आ रहे हैं वो भी 2 ही हैं.
हाँ
दैट
तो
इज द
ठीक
प्रॉब्लम.
है,
ये
तो
तो
उसके
ये नहीं है कि
साथ
बहुत
जाओ.
नंबर्स पीछे आ रहे हैं.
Go with follicular stimulation, take out the eggs, and then stimulate again in the luteal phase. You can do a duo stim for her.
Yeah, okay. Thank you, ma'am.
Okay. I think what
Much,
time?
Abha ma'am,
Huh.
it's past 8. I think this species discussion can go on for
Yeah.
hours, but we have to stop. Thank you so much, Dr. Abha ma'am. It is always a pleasure to listen to you, and all of us wait for your master classes. We are wiser each time that we listen to you. Thank you so much for all your efforts.
I get wiser by your questions and I rethink about what practices I do. I think a lot and I change my practices, and I think everyone is witness to it. I used to be a great fan of Clomiphene. I changed to Letrozole. I used to always say Letrozole, hyperandrogenic लोगों में Letrozole क्यों दे रहे हैं हम लोग इतना 10 years ago, and then 5 years ago also I used to use. You must have seen me using. A lot of
Right.
things have changed in the way when you see the responses, when you read articles, you look at more logical answers. Thank you very much for giving me this opportunity to take a class and to revise my views and listen to your views and become enriched in whatever how we work. Thank you, everyone.
Thank you,
Thank you so
audience,
much,
for
ma'am.
joining in today, and thank you, team, for supporting our master classes. Good
Yeah,
night. Thank
where
you,
is
ma'am.
our team? Where is our team? Mr. Dua, are you there? Today I don't see Mr. Dua. Okay, thank you very much. Thank you, team, for supporting.